All right. Everybody ready for more? Dr. Purdy stands between everybody and lunch, so. I know I ran over, but thank you for your patience, Drew.
Yep.
So, Dr. Purdy, 86? 85? When did you get here?
Oh, 87.
87, okay. So, for 35 years, Dr. Purdy's been...
Go ahead.
Go ahead.
36.
Who's counting? 36.
Yes.
Yeah, you're right. That's 36.
Yep.
So over 35 years, Dr. Purdy has been participating in our healthcare community here and really had been one of the people that congealed our current group back in 1993. He's mostly from Nebraska, but yes, we shared the same town, Mitchell, South Dakota, for a little while. And then you went back to Nebraska to Creighton after USD. And you've done wonderful things for us here. I'm so appreciative that you're still involved in education. You're still involved in seeing patients. You're still involved in research. There isn't much you're still involved in, and I'm grateful for that. So thank you, Dr. Purdy.
Thank you. All right, thanks everybody. Kind of focusing on wellness, I think for a couple of reasons I decided to kind of focus a little bit more on elderly patients, because I think a lot of elderly patients get excluded from a lot of research studies in groups. I mean, a lot of the information you've seen today on lipids and that kind of stuff does not include patients above the age of 70 for the most part. I think people who tend to sign up for studies, and therefore the majority of the population are, white males somewhere between the age of 18 and 65, and so that's what kind of most of our knowledge is about. So I wanted to pick out some trials that I thought reflected care of the elderly, because I think a lot of times when you get to a certain point, people say, what's the purpose of, putting for primary prevention a 75-year-old healthy person on a statin or something to lower their LDL cholesterol. And so I kind of wanted to look at that, and also wanted to look at, on the interventional side, exactly what we do and how it benefits the elderly population. So we'll kind of start somewhere in there. But first of all, we're talking about things that can make a difference in terms of patients' cardiovascular health. And one of the things that we haven't talked about is really physical activity. So there was a large study that was done out of Taiwan, and recently another very large study in the Netherlands. They have the benefit of having a population that's kind of held close to home, and they don't travel a lot or go places or do very much, and so they have very large registries, and they're able to look at all this data. And they can look at data, and they can put out questionnaires and do things and look at things really specifically, especially in terms of physical activity and exercise. And when you think of your 85-year-old patient who comes in with a walker or a cane or, needs a step replaced or whatever, you kind of think, don't talk to these people about exercise, because, they're beyond that. It's not going to be helpful to them at all. But in actuality, it's probably one of the most beneficial interventions we can make. So what is really the health benefit of physical activity? How much do we need? We always talk about 10,000 steps. Is 10,000 steps enough? Is 10,000 steps too much? Is there a negative to additional physical activity? I think when it comes to, more advanced therapies such as running, like the marathon runners and ultra marathon runners and those people, I think there's a huge evidence to suggest that that's not good for you and your aorta. So I think that, everything in moderation, and that includes physical activity. But how much do we really need? So what's the least amount of activity that actually benefits the heart? I don't think we've ever really found that out or know. And, I don't wear my phone all the time, but sometimes you get home and it'll say, hey, congratulations, you put in 1,700 steps today. I don't wear my phone the whole time. I probably put in more steps than that. But is that helpful? Does that really make a difference? Getting up and walking to patients' rooms and around through the cafeteria and places, is that helpful or not? And then how can we motivate patients to increase their levels of activity? So again, we're talking about mostly elderly patients. So there was a when and all published in Lancet. This was about 10 years ago, but combined with a more recent study demonstrates significant things. I looked at people in Taiwan, 400,000 participants over 8 years. So they classified people's activity as vigorous, moderate, or just total activity times that they were actually moving. And they found that almost any level of activity induced benefit. And 15 minutes of vigorous physical activity, and by physical activity, they kind of counted it in terms of cadence. So those of you who are bike riders know cadence is the intensity and how fast you're moving your feet to increase your exercise. And so rapid movement, 15 minutes a day, reduced cardiovascular mortality 20% over 8 years. That's a big deal. 30 minutes of moderate activity had a similar response. So if you're not going to be really physically active or intense activity, you have to exercise for a little bit longer. But again, over that time frame, about a 20% reduction in cardiovascular mortality. 45 minutes of vigorous physical activity reduced all-cause mortality by about 50%. So this is a slide that comes from that study, and as you can see, on the far left, the really vigorous activity, I mean, look at the significant benefit all-cause, not just cardiovascular, all-cause mortality in patients with just 35, 40 minutes of exercise, 50% total reduction. And not only physical activity, but even things like balance. I had a discussion with Dr. Purdy the other day. His dad is a physician in Nepal, and one of the most important things, I mean, if you can do certain things with balance, so you're not going to fall, you're not going to break your hip, you kind of keep the whole system upright and working. His dad, to this day, I don't know how old he is, puts his socks and shoes on standing up. I mean, most of us sit down, but he works on his balance every single day to do that. And many studies have showed that is a significant benefit in terms of long-term all-cause mortality. Just people staying active, working on their balance, keeping their physical strength up. And as you can see, the less intense, you still get benefit, you just have to do it longer. So this is from the STENS trial. So this was the Netherlands, and again, they have all these people in this tight-knit group, and they can monitor and follow their physical activity level. And if you look again at the steps per day, and you look at all-cause mortality, I mean, there's definite relationship. Even a small number of steps per day is associated with all-cause, and in this incidence on the slide to the right, cardiovascular morbidity and mortality. So even small amounts of physical activity. And so they went through it and they kind of looked at it and tried to figure out exactly how much it took to demonstrate significant benefit. And these are kind of how they came out, that in patients 0 to 2,500 steps didn't really help very much, but more than 2,500 steps a day, which really is not a lot. More than 2,500 steps a day, you start seeing cardiovascular mortality benefit. And as you increase that physical activity, their activity level went up to about 9,000 steps per day, so lower than our current recommendations, and found that it kind of tapped out at about that point, didn't seem to get a whole lot of more physical benefit beyond that. But still, even 2,500 steps a day. So when, your elderly patient comes in and he's not very active, I mean, even getting him to get up, walk, go do something, is going to benefit him significantly in the long run. So in that STENS trial, 11,309 individuals from the Netherlands, reductions in all-cause and cardiovascular mortality. Again, the harder they worked, the better they did. They noticed that Apple Watches and watches of that type, I mean, it doesn't necessarily record what your level of physical activity is, as well as a hip-worn device. So if you have something on your hip where you have the muscular contraction in your hips and things when you're walking and doing that sort of physical activity or riding a bike, seems to be more accurate than a watch or pedometer or any of the other devices. So That's what they recommended. And it didn't seem to matter, males, females, everybody benefited. So good news for patients, especially our obese patients or elderly, that even modest levels of physical activity and low-grade activities were associated with benefit. So again, the most important thing for advising our patients is to just get out and move and just do something. A lot of people, they come in and they say, yeah, I walk 5 miles a day. How long does that take you? Oh, about 30 minutes. And I'm like, yeah, I don't think so. But I mean, really, to encourage them that even though they may have other physical disabilities, restrictions, if you don't use it, you lose it. And so it's important for them to continue to be physically active. So the other thing I want to talk about for a little bit is we've over the 25 years we've been putting on this program and the 36 years I've been here, we've gone from pretty much strictly femoral access for cardiac catheterization to radial. And in our lab, presently, we're close to about 80% radial cases. I think the cases that we do femoral are people that have either don't have good access from radials, that maybe they've had the left radial used for a bypass graft or something, or they've had the right radial used so many times that you can't get through anymore, or they're putting in like an Impella or some sort of support device. And so those are people at high risk anyway. But when you look at radial versus Impella, or radial versus femoral, there's a lot of significant differences. And I think when we look at our statistics, and Clinton can tell you this, when we look at our statistics and we look at our treatments and our mortality outcomes for STEMI and non-STEMIs, we are significantly better than the rest of the population. And also, when you look at all that data too, you find that we probably are in the top quartile for radial access. And so I think that demonstrates probably why we're doing a lot better in some cases, because there was a very large meta-analysis. So they went and looked at all these different studies that compared radial versus femoral, looked at all the data, and they went down to each individual patient and looked at bleeding and other sorts of complications and problems associated with femoral versus radial. So if you just do radial cases versus femoral cases, it was a 24% relative risk reduction in favor of radial access. So they had less bleeding, they had less vascular injury, their time getting up and moving was a lot faster, and because they had less bleeding, much lower risk of anemia. So in patients who get thrombolytic therapy, which because of our geography, we have a lot of patients still that get thrombolytics before they arrive in our cath lab for STEMIs. If you use the radial artery, significant benefit there because you're not in a patient fully anticoagulated, poking them in the leg in a big artery that's going to end up having to be pulled at some point. And when the patient's going to be anticoagulated for hours, almost a day after thrombolytic therapy. So you would think radial, I mean, you go past the carotid artery and everything, maybe a higher risk of stroke. There was no significant markers suggesting a higher risk of stroke in patients with radial access versus femoral. Because you're injecting dye up above, and rather than going through, passing the kidneys, and perhaps causing atheroemboli to the kidneys, there's a lower risk of acute kidney injury, mostly contrast-induced nephropathy, but probably some atheroembolic disease as well. And high-volume labs did even better than the 24% reduction in relative mortality. It was almost a 50% reduction in relative mortality, and I think that's probably where we are because we have high volumes and we do a lot of cases. So much so that the European Society of Cardiology, American College of Cardiology now has listed radial artery access as a class 1 indication for patients with acute coronary syndrome, STEMI or non-STEMI, just because of the lower mortality associated with it. And so I talked about that a little bit. The radial access has allowed us to achieve, I think, what we feel are very good results for our community. And I think also the important thing that we always get talked about every day is patient satisfaction. So if you have a patient and say, okay, that you've had a cath done from your leg and you've had a cath done from your radial artery, what would you prefer? 70% of them say they prefer radial. In fact, about 20% of people, when you discuss cardiac catheterization with them, if you say, you know, we've used your radial, this one's included, you know, you should have a heart cath, 20% of them say, no, you're not going to do that again. And similar, I mean, when you know, if you ask people if they'd rather walk on a treadmill or get adenosine cardiolite, a lot of them say, I will never have a chemical stress test again. They would much rather walk on a treadmill. So we got to look at patient satisfaction as well. So keeping with the theme of elderly patients, just in a recent JACC, there was an article that looked at LDL reduction, primary prevention in individuals above the age of 70. So a lot of these trials are data driven. I mean, they're based on, you know, observational trials, not really randomized controlled trials. But when we look at these, we're trying to figure out, you know, what is really the benefit. Does anybody know? No, because they've been excluded from almost all the trials. So is there an actual benefit to putting a 70-year-old on a statin drug as primary prevention? So no history of cardiovascular disease. They haven't had a calcium score. We don't know what that is. We just know that they're at risk because their LDLs are high. So what is the benefit? So they used a Denmark National Data Group. They looked at a whole bunch of patients from 2008 to 2017. And they excluded a bunch of them because they either had coronary disease or they had something else going on or they had previously been on statins and were intolerant. But out of the group that they had looked at, 65,190 people made up the cohort for the analysis to look at. So the majority were female, which is different than what we typically get in our studies here. And it didn't seem to matter what the educational levels were, education, income levels, everything was pretty similar between both groups. Baseline LDL cholesterol, incidence of diabetes, hypertension, and all the other cardiovascular risk factors were fairly identical. As I recall, the LDL cholesterol, average LDL cholesterol was like 140, so not dramatic, but certainly not in the area that we'd like people's cholesterol to be based on their cardiovascular risk factors. And obviously, elderly patients tend to have more advanced coronary disease, even though they may not have symptoms. They tend to have more diffuse coronary disease, more calcified coronary disease. So you kind of think that, you know, the cat's out of the bag and there's really nothing to be gained by doing much for these individuals at this time. But what they do is they looked at these groups and found that whether you were under the age of 70 or older the age of 70, the cholesterol reduction was identical between the two groups, 63 milligrams per deciliter, so that's a pretty fair amount. And what they also found is when we're looking at relative risk reduction, so 23% reduction in major vascular events in people, even though they had no coronary disease, they were 70 years old, you know, their cholesterols weren't dramatically high, and this study was performed or followed over a period of time. So there was, I think, 2.8 years of follow-up. In 2.8 years, in terms of cardiovascular risk reduction, is not that large amount. And so I thought it was a fairly dramatic reduction, really, in people who probably already have extensive disease. So 30% reduction, relative risk reduction for acute coronary syndrome, 17% reduction in hemorrhagic stroke, 30% reduction in need for any coronary revascularization during about 3 years of follow-up. 23% reduction in major cardiovascular events per 1 millimeter cholesterol lowering, very similar to the data that John had given earlier about 20 milligram per deciliter reduction equals 10% reduction. So, but no reduction in all-cause mortality. And I'm certain that if you track these people over a longer period of time, a lot of people died of other problems, not necessarily cardiovascular disease. So then what they did is, having all this data, they looked to see, okay, well, where does the benefit stop? That means they looked at 70 to 74, 75 to 79, 80 to 84, 85 and above. And basically, there appeared to be no significant difference in cardiovascular disease reduction between any of the groups. So they all demonstrated at least a 23% relative risk reduction, 30% cardiovascular risk reduction, and need for intervention in the groups even above the age of 85. So you kind of look at the data and putting everything together, and I think it's important to sit down and have that discussion with them and just say, these are the reasons why we think it might be beneficial to you. And then again, have that discussion. Do you want to do it? Do you not want to do it? And call us if there's problems. So anyway, so it didn't demonstrate a mortality reduction, but there was a very large trial that was a retrospective trial that looked at all the information that was performed by the Veterans Administration in the United States. And what they did is they had a 2.5-year mortality follow-up, new initiation of statin in a patient above the age of 75, followed for 6.8 years. So these were probably pretty healthy overall 75-year-old people, and demonstrated a significant reduction, greater than 20% reduction in all-cause and cardiovascular mortality in patients treated above the age of 75 for an LDL cholesterol averaging about 135. So again, have that discussion, something to think about. The medicines work the same. There's the exact same statistical benefit in LDL cholesterol lowering, and no matter the age, there appears to be overall relative risk reduction no matter what your age is. So then, if your patient who maybe didn't get his cholesterol drug or was taking his cholesterol drug comes in with acute coronary syndrome, then what do? So again, patients who are above the age of 75 have more coronary calcification, more advanced disease, more triple vessel, more left main, more multi-vessel disease than our average patient who's probably 55 to 64 STEMIs. And that was the FIRE trial, and the FIRE trial was performed in different centers in Spain and Italy. And so they were actually able to completely randomize this. And so as patients would present to the ED, STEMI, or acute coronary syndrome, they were randomized immediately, went to the cath lab, and then they were intervened on. So, something got out of order. Okay. So, and the way that they intervened on was they intervened on what they felt was a culprit vessel. That's what they did first. So brought him into the lab, intervened on him, and then they looked at the other anatomy and said, okay, is there any severe anatomic, visual, 70, 80% stenosis, and fix those at the same time. Or if it was marginal, they weren't really sure, they used FFR to assess and decide if it looked like it was hemodynamically significant. If it was, they fixed it. So totally random, one group culprit vessel only, and the other one fixed whatever you could, whatever you thought looked significant or was proven hemodynamically to be significant. And then they monitored those patients over, again, a relatively short period of time of several years. So 1,445 patients were randomized, median age of 80. So primary outcome, death, myocardial infarction, stroke, or any repeat revascularization procedure. Secondary outcome, cardiovascular death or MI. They looked for, stroke, contrast nephropathy, because you're getting more contrast if you're doing more vessels, more radiation, your longer period of time on heparin or whatever anti-thrombotic drug you're using during the time of the procedure. And there appeared to be no significant safety problems between the two groups. So 720 received what they felt was complete revascularization, 725 culprit vessel only, 35% were STEMI, 65 non-STEMI, and 37% female. So they went back and looked, and in terms of cardiovascular risk factors, creatinine clearance, ejection fraction, all the other things that you look at that may be important factors for mortality were pretty identical between the two groups. Smoking history, use of statins, et cetera. So pretty comparable groups because it was randomized. So primary outcome occurred in 113%, or 113 patients in those who got complete revascularization, or 15.7% of the patients ended up having one of these major outcomes. 152 patients in the culprit-only group, 21%. So 5.3% absolute reduction in the risk of the primary event. Most of those were driven by repeat revascularization. Even though they were treated aggressively and they all had medical therapy, guideline-directed beta blockers, ACE inhibitors, ARBs, depending on their ejection fraction, statin drugs, et cetera, and had fairly identical cardiovascular medications over that period of time. They had the same percent of people on Plavix versus ticagrelor versus prasugrel, and so there wasn't any real benefit in terms of antiplatelet therapy because they were pretty much identical. But when you look at cardiovascular death, or MI, 64 patients in the complete group versus 13.5% of patients in the culprit-only group, even though really everything was pretty similar. So a pretty significant reduction. No bleeding, contrast-induced nephropathy with either strategy, a higher risk of stroke or TIA, and the majority of them were defined as stroke. TIA, I think it was 8 and 11 in the complete revascularization group, 8 in the incomplete group, but 24 versus 11%, which was not statistically significant unless you're one of the 13 people that ended up with it. So everything was pretty much identical. Target vessels treated identical. So overall, even for a relatively short period of time, I thought it was a pretty amazing study to see that much difference. So things that we talk about to patients when they come in include patients who have hypertension, often have sleep apnea, patients with atrial fib, sleep apnea. So CPAP is important. So this is just a really quick trial that looked at the effect of CPAP therapy as a secondary prevention tool in those patients who have known cardiovascular disease. So they had to have a certain number of hypopneas. It was 30, greater than 31 apnea-hypopnea events, 82% men, 71% with hypertension. And they reviewed all the records they saw based on their little card and diary, how much they actually used it, and the majority of them used it for greater than 6 hours a night. So individuals who had a good adherence to CPAP therapy, as defined by hours utilized per night, showed a reduced MACE recurrence risk, suggesting that treatment with CPAP is a key factor in secondary prevention. So I think that, we always tell them to, but now there is evidence to suggest that they really do. And I just want to drop this on you because I think that this is going to be important. Maybe Roger's going to talk about this a little bit later today. So we all know, forever and ever, the only anticoagulant we ever used when I was in residency program or as a fellow was warfarin. That's all we had. And until just really, frankly, the last 15 years, that's all we had. And so the problem with warfarin is warfarin as a vitamin K antagonist affects multiple factors. And it affects protein C, protein S. So it affects a lot of different things. It takes a long time for it to get into the bloodstream, it takes a long time to get out. You can reverse it fairly readily with vitamin K, but it's a hazard. And because it affects so many factors, there's also an increased risk of bleeding. And so Novel agents then came out, which affected either direct thrombin inhibitors or they were factor 10A inhibitors. And they only affect the one particular factor. And so what we saw is similar benefits in terms of stroke and no significant increased risk of bleeding, and in a lot of studies probably a lower risk of bleeding. So that's all great. So what is then on the horizon? So what's on the horizon is specific factor 11 inhibitors. And these factor 11 inhibitors, there's going to be a whole bunch of different types. How they work, there'll be the small mRNA, and Alex talked about DVT prophylaxis. Some of the small MRA injections that you can give work as an anticoagulant for 30 days. So, as they're heading out the door after their hip replacement, you give them an injection of that. They're anticoagulated for the next 30 days as they go through rehab. They don't have to take a pill. They don't have to do anything else. They're anticoagulated. And the reason they target factor 11, if you look at the whole cascade, factor 11 is extremely important in terms of thrombus propagation. So if you get a thrombus, it just keeps the whole factor going. But if you inhibit it, then you get an anticoagulation effect. But factor 11 is not really important in hemostasis. So you can block factor 11 all you want, and it really doesn't affect your clotting that much. If you have like a bleeding incident, a cut, something else, the hemostatic system still will work, but yet the patient's anticoagulated. So there's going to be a lot about this coming up in the near future. Like I said, there's going to be multiple different drugs, and I think it's going to be great. So those of you who have spent a lot of time looking at all the factor 10 inhibitors and all that stuff, 5 years, that'll probably all be gone. It'll all be factor 11 inhibitors. So doesn't mean don't study and learn it now, but I think it's probably going to go away because this is so much of a better drug. So that's all I have. Questions?
This is the interactive part. I'm not sure if you guys.
Come on, Cheryl, you've been asking every time something.
It means I was perfectly clear.
Amy has a question? No. You're just volunteering somebody that was a friend now is an enemy?
Where to
Okay,
get my
Cheryl's got
tie?
one.
Something.
I'm curious about, we were talking about physical activity. Have you seen a difference in people who had COVID and how they're exercising or problems with exercise after having COVID?
So the answer is yes. I think a lot of people have respiratory problems and difficulties afterwards, and a lot of them are more limited. They don't do as much physical activity. But on the other hand, a lot of people, including our family for one, made it an advantage. If you don't want to be around large groups of people, what better way than to take your family and go on a hike? You got 5, 6, 7 people together that you intermingle with all the time. Go out and walk 2 miles and then enjoy yourself, come back. And so I think early in COVID, when everything was shut down, that was our family physical activity thing that we did together to avoid everything else. So can't say that it kept up entirely. Things in life change, and kids get older, and grandkids don't necessarily want to hang out with us anymore. So as things happen. But in general, patients, I think, if in the COVID era, I think there's been more people outside doing other activities. People who got COVID are probably less active because I think they have still some degree of limitations for a fair number of them. Affect their heart rate. Well, I think anytime somebody is more physically active, their heart rate generally is going to be lower. Higher vagal tone, slowing the heart rate down a little bit. We are only given a certain number of heartbeats in our lifetime, and the slower your heart goes, for the most part, unless it's really slow, the better off you're going to be. So I would say those people who are better physical condition are going to have a lower heart rate. Runners, those people typically run with heart rates in the 40s or lower at rest. And I don't think it's a matter of conditioning. I find that it's really difficult when I or at home on a treadmill. I did have COVID. Got it in Alaska. Thank you, Sam. Well, Sam wore a mask. I didn't, so it's my own fault. But it just seems like it's really, really difficult as I've aged to get my heart rate up higher. I don't know why that is, but it just seems like it's harder and harder all the time. So that's my own personal story.
Danette had a question, but she didn't want to ask it because it would make lunch later. But the question is, as far as how far along are we with Factor 11 trials to get to the point where we don't need Coumadin for valves?
I'm not sure that we'll ever replace Coumadin for valves. They've looked at it, and I know that there's an ongoing trial with Eliquis in Onyx valves. And I'm not sure how that study came out. I think it's still ongoing, but it didn't work good. Yeah, none of the NOACs have been beneficial for mechanical valves. So so I think that probably warfarin is going to be around to stay indefinitely. But I mean, Factor 11 inhibitors, I think are going to be really dramatic. And Roger will have some additional information because we're doing a couple of trials in atrial fib and acute coronary syndrome. So we'll have some data, hopefully coming up here in the near future, but it's going to be a few years yet.
With that, we will end our questioning as you all look very hungry.
We'll get back about 1:20, I would say. Okay?
Okay.
Thanks, everybody.